Hello everyone. It must have been a really long day for all of you. So after having heard, from my very dearest colleague Gemma, who really spoke about crisis action, and others who spoke about, initiatives in agriculture, I'm going to actually take you to India. I realized that my colleagues actually spoke for longer than they should have been. So I can truncate a little bit of my presentation. But this is more like just to give you a broad sense of Indian healthcare. As I was getting introduced, the most fascinating part that I like about my journey is that after I finished my PhD back in 2007, wherein, I was in Zurich, busy making drugs and all of that, you realize that how much of a bubble you live in, when you have all the resources, you write research grants, and then, you work on a project for 5-6 years, write a really fancy thesis, and that's about it. It does actually, if you work on those projects for long enough, a couple of decades, they do at times yield into blockbuster drugs, as they are popularly called. But most often they are reasonably far away from the reality that you see on the ground, the reality of a common man, the reality of 1.2 billion people who are there in our country. And the common reality over there is that most people in our country have never seen a doctor for their entire life, because there is very limited need for them to actually go and see a doctor. And even if there is a need for them to go and see a doctor, there isn't a doctor for them to go and see. And that, I think, back in 2007, was too much of a dichotomy that I was facing. That do you go back into a bubble and, spend the rest of your life in that bubble creating things that can be interesting? Or do you really go around creating market-driven solutions and impact real people in the lifetime that I'm around? I chose the latter because I thought it took me closer to people. And I got to do some very, very interesting things on the ground. So most of my talk actually is going to be about that. And I have a bad habit. I don't like making presentations. I like talking. So I almost feel very disconnected when there's a slide behind me and I need to go back and look at the talking points from the slide. So I spoke a lot of this about, when you speak about our country, we all know that we are around 1.2 billion people. If you do the math, which has been given to us by the World Health Organization, as a country, we need around 1.2 million doctors. We have only 400,000 doctors available in our country. You take all the medical colleges that are available in our country and add all the doctors that are being produced every year, the number is only an unimpressive 30,000 doctors. So there is no way that we can ever, as a country, produce enough doctors for our country. So what do we really do? So for the doctors that are available, so our country, most of our country actually lives far and outside of the big cities that you actually see in, if any of you has been to India, what you see is just 20 or 30% of our country. Most of our country actually is living in rural parts and in villages. Now, for those people, most of the healthcare infrastructure is actually sitting in big cities. So there's an interesting dilemma over there that most of the medical infrastructure is urban, and most of the people are living in rural economies. So we have very few doctors, and in those few doctors as well, there is a very strange distribution. Everybody is just cluttered together. Everybody likes to be in a nice, very big, cozy, multi-speciality hospital wherein you're paid well, and everything is taken care of, and you actually work on the area of specialty that you work with. So that doesn't necessarily add up well. The other good thing is, of course, everybody talks about India shining and India doing really well. This is the shining part that fascinates me. We are the diabetes capital of the world, the cervical cancer capital of the world, the road traffic accident capital of the world. So you name it, and 1.2 billion people are trying really, really hard in absolute numbers to add up to that fact, which isn't very great. Now, what is also going on is the huge shift that you see in, the kind of diseases that we are seeing in our country. So let me take you around 60, 70 years back when we actually got our independence. What was the most important thing that the Indian government wanted to do? The Indian government wanted to fix everything else and health. And in health, the Indian government said that, health is a right, and we want to make sure that as a government, we will provide health care to all of our people. Now, when the Indian government started doing that, up till 80, there was absolutely no private sector which was available in our country. Most of it was within the government sector. Now, within the government sector, what were the priorities back in 1947 when we got our independence? The priorities were dying mothers, dying infants, dying, lots of communicable diseases. There was malaria, there was polio, you name it. The priorities were very different. You fast forward around 70 years, not that we have impressive IMRs right now. Our infant mortality rate is still in the 40s, but it is way down the 3-digit number where we got started, many years ago when we got our independence. Similarly for maternal mortality, similarly for many communicable diseases, we've gotten rid of polio altogether. So we've done reasonably well on some of the areas. Now what has happened is that the entire epidemiology has seen a huge shift in chronic diseases. And in the previous slide, I actually spoke about how we are really becoming a chronic capital of the world. How are we dealing with it? Now think about a scenario when you have a mother who's actually in labor and she has to deliver. The kind of system that you would need to respond to that mother to make sure that she goes through a safe delivery is very different from the kind of system that you would need for, say, a diabetic patient. The two interventions and the strategies are very, very different. So as a country, there has been a complete flip in the kind of diseases that are important to us. But our healthcare systems are flipping from being completely government-driven to private sector becoming very, very, very important today. Now let's really look at what's happening with expenditure. India spends around 4% of its GDP on healthcare. Out of 4% of the GDP, only 1%, or a little less than 1%, is actually 0.9% is what comes from the government. Now if the government is spending so little and the people are spending most of the money, and in a country where the health insurance penetration is only 15%, you can imagine that the health expenditure is very non-volatile, or is rather very catastrophic for the families who have to go through it. It's very unpredictable in its nature, because you might not have anything wrong with your health for many, many years, but when you do, you need to sell all your assets, you need to liquidate almost everything that you have available with you, and health expenditure continues to be the single largest reason for Indians to fall below the poverty line. So this is a huge problem. Now, the good side, or the positive side of this, is that if in a market there is a service for which most of the people are paying out of pocket, there's a huge opportunity as well for the private sector. The private sector in terms of healthcare, whether it is medical devices, whether it is pharmaceuticals, whether it is technology, whether it is talking about primary care and all of that. And that's what you've seen in India. Back in the 80s, when the government realized that they are really not doing a good job of providing healthcare through the government facilities, the private sector actually started doing very, very well, started emerging. We started opening really large multi-speciality hospitals, and they became kind of the focal hub of the private sector beginning to do very well in healthcare. In the 80s and the 90s, we had very, very large multi-speciality hospitals that took off. Early 2000, single specialty hospitals started becoming very important, whether it was around maternity, whether it was around ophthalmic interventions, whether it was around dentistry. And now what we're really beginning to see is a lot of emphasis on primary care, on technology-enabled care, on telemedicine, and interventions like that. So what are really the entrepreneurial avenues? What I really wanted to do is, this is not a full representation, but just to tell you which are the big buckets in which a lot of innovation is going on. So the first one is nationwide. This is a gastroenterologist from the National Health Services in the UK who decided that if in the UK you can run an entire country on primary care practitioners and the kind of work that of gatekeeping that is of reasonable efficiency in the UK, why can I not bring that concept to India? So like for Dr. Shantanu, who's running nationwide in India, there are many, many, many practitioners, including ourselves, who are working in the space of primary care. So there is healthcare service delivery, which is seeing a lot of work, and that's one. The other space which is actually seeing a lot of innovation is that of medical devices. And when we talk about medical devices, we are really talking about this device that I chose. And this device that I chose is for a simple story. So in India, we have around 80% prevalence of anemia, which means 8 out of 10, literally 9 out of 10 women, because prevalence also has men in them. So 8 to 9 out of 10 women are actually anemic. Now, there's a very simple test to check for your hemoglobin levels, but it involves a prick. You need someone who's medically trained to be able to prick you okay, and there has to be a reasonable amount of hygiene that has to be involved. So these fellows came up with an idea saying for a pulse oximeter, you don't need to prick anybody to really get a sense of how much oxygen saturation is there. Why can't I use the same technique to tell the amount of hemoglobin that is present in your blood? So they really came up with prickless ways of testing for hemoglobin. Now, these are the kind of interventions with the entire network that we have with around 1 million health workers, health posts, people who are not necessarily technically very trained, but can be empowered with technologies like this to really integrate them with the larger healthcare ecosystem, I think are also very significantly changing our scenario. The third space is that of impact investing. And within impact investing, there is something very interesting going on. The only distinction I would make of impact investing and the distinction from a venture capital is that they have the word impact in them. There is a lot of work that is going on currently to really define impact. Is impact just output, saying how many people did you touch and how many lives did you have, or is it really an outcome? And I think, especially the healthcare impact investors that I have seen, it's tough to answer those questions. Just because if you're present and you're providing services, is that good enough? Or are you truly concerned about the outcome? I can't speak of other spaces, but in healthcare, to be able to measure outcomes is not that easy. To be able to say that this intervention has actually impacted the community in a positive way, that's hard. I've done healthcare entrepreneurship for 8 years, but I don't think there are straight answers for that. So it's an interesting space, but which I'm hoping that in the next decade or two will actually evolve very significantly and will really bring in and redefine the whole impact part within impact investing. So those are just quick reviews of what has been done. I have the light glowing on me, so I need to quickly finish. There's a cheat light here. So what I'm going to do is tell about the work that I did for 8 years as the founder of an organization, is to say that I was very fascinated by creating a market-driven solution for healthcare for people who live in villages. So how did I go about doing that? I told you that we didn't have enough doctors, so we went and partnered with the University of Pennsylvania and brought the nurse practitioner model to India for the first time. We partnered with the largest medical provider in India, and are now scaling the nurse practitioner curriculum in the next handful of years that we will see. In terms of technology, when you think about a healthcare enterprise, there are many solutions that you will get for patient record keeping. There are many solutions that you will get for supply chain management. There are a gazillion solutions that you will get for performance management. There are many other things that you will get for mobile technologies. That's great. But if you are sitting as a CEO of a startup, you cannot have 75 different solutions in technologies that you have and then figure out to put data from one to the other and have one talk to the other. So you need something which is integrated, something which looks at healthcare as an enterprise and actually creates an enterprise management solution. And that was our attempt with technology, to actually create an enterprise management solution for healthcare delivery, which does everything from patient record keeping, supply chain management, performance management, really bringing together functions that you would need if you wanted to do healthcare other than charity, or if you wanted to look at healthcare other than the lens that a doctor would use to look at healthcare. So that was primarily our attempt. And in the attempt of really using nurse practitioners enabled through technology to deliver healthcare, there was a lot of standardization that followed. All the protocols that we wrote, all the standard methodologies that we had, a huge emphasis on community engagement were things that kind of followed. If I had more time, I would have given you details of all of it. So I'm going to click on everything. So this is primarily to give you a sense of the operating model. So we have one clinic which will have a doctor and a nurse. The doctor is primarily the nurse practitioner and the nurse is the community health worker in our case. They have a calendar to follow. Each clinic has a customized calendar that is created for them. And a calendar draws an appropriate balance between how much time they spent in the community and how much time they spent in the clinic doing different activities that they're supposed to do. All of this is supported by us, which is the back end, whether it is making sure that the drugs are available on time, the clinic opens and closes on time, there is monthly assessments which is done to see how many patients did you touch, how many came back, how many new patients did you saw, the chronic patients that you had, how are the chronic patients doing on their diabetic profile, and things like that. So that is primarily stuff that we have been doing. And I can speak about all of this stuff in good detail, but I think an easier way of doing that is to actually show you a 59-second clip, of our work, which is from an award that we recently won at a national level, really recognizing our work. So with that, I will just move on to the clip, and then we will close the presentation. With that, I thank you all for your attention. Thank you.